my talk about work which has been done in last decade on the control of progression of myopia, the pharmacological aspect of it. And thank you so much, Shruti, for the wonderful introduction. Thank you a lot for making me part of this wonderful session and wonderful lecture by Dr. Aloka and Dr. Rashina and Dr. Koheri, of course. Atropine for myopia is now, most of us who are into this myopia thing, we know that atropine works for myopia. And I think most of us also is that we don't have much on theories of how it is working, but we have a working hypothesis that it is because of the dopamine release in the eye. And so this was one of the landmark trials which was done by Singapore. Yes, there have been studies before this also, but this was where it all started way back in 2006. But this was 1% atropine, and they had done an RCT. They had double mask placebo controlled in one eye, so they had control of the same patient. So this was very classical, and they had very strong, they had a very good response to atropine 1%. And then they tried to tweak the concentrations, and this was another landmark trial where they could find that atropine 0.01% was as effective as 0.5. So they did find that this was dose-dependent response, but they did not find it that the difference was not very significant, and they found that over a period of 5 years, so they found that for 2 years when you use atropine and then you stop using it for another year and still you use it again, over a period of 5 years they found that atropine 0.01% eye drops were definitely more effective in slowing the progression with very minimal side effects. So these are some of the advantages of low concentration atropine. Almost no effect on accommodation, and systemic side effects. Obviously, when you reduce the concentration to such a low power or such a low concentration, the systemic side effects are also very, very minimal, though there have been some. We will see. Because what they did was they went further and they made very small changes in the concentration. This was a randomized controlled trial, placebo controlled, strict follow-up, axial length measurements were taken. Very small steps in concentration changes from 0.01%, 0.025, and 0.05. And they found that 0.05 was definitely more effective than 0.01, but still why 0.05, why 0.06? So there are multiple questions which still remain unanswered. What is the optimal concentration? They did find that 0.01% has a role, but 0.05% was much more effective, and they concluded even after 2 years their phase 2 study. This was the same group where they found that younger age is associated with poor treatment response. So if you have a child presented to you at a younger age, he or she may be at a poor treatment response group. And they also concluded that there was no other biometric change except so where does all this literature lead us to the fact, most important, that atropine does work. It is concentration dependent, but 0.01% does hold value. In non-responders, well, this is not really documented, but yes, if they are not responding, we may switch higher concentration. At this point of time, we do not have 0.05% eye drops in India. And at this time, we are using by reconstituting atropine eye drops, which we were doing in 2013 when 0.01% was also not available. This RCT we had presented in AIOS in 2018, and we found that atropine was definitely more effective compared to if you don't have intervention. And this was a longitudinal study for 358 children. Our results are very much comparable with what we showed and what has published now by Rohit sir's group in 2021, but they had a 1 year follow-up. And so this was the same study on LCA. These are all our studies which we did show that still plays a huge role, and in a very small questionnaire we found that 14.8% did not continue the drops regularly, And this was to compare in pre-myopes. Now that we have we know that there is a entity. We feel that they are more susceptible to going into quick progression. As Dr. Kohli's video, she showed that you may have you can have if you have a black higher, if you have a high AC/BI ratio, there are chances that this patient may go over myopia progression. This is the data. So my point being that it does work in pre-myopes. We are waiting for single versus twice a day usage low concentration treatment once the lamp came in 2019, and being definitely more effective than once a day. And nowadays you tend to start with twice a day approach also. We also tried to use twice a day approach in 30 non-responders who were having protection despite using low concentration atropine eye drops, and we found that almost 30% of them did respond to twice a day dosage. And we also the correcting myopia terminology, which Dr. Sheena mentioned, we tried to see our patients were not were already not on atropine, despite they were told that they should be on atropine and were progressing. They started progressing at almost double speed than what they were progressing before quarantine. We did patients who we had they do shift. There is a myopic shift, and we started using low concentration atropine at the age of 4 years. Once they were 4 years of age and they were still progressing, and we found that this was indeed useful in those pseudophakic patients. And so this concludes that atropine, low concentration atropine, is not working secondary to accommodation or accommodation. This is very important. Most of us get away with low concentration atropine without any problem. A small set of patients who may have allergy to atropine, and they may come up with this response. There may not be any response to cumulative effort, although not inhibited, but still there have been few who have that there are esophorias post atropine eye drops. It's just a paper to know the safety and efficacy of low concentration atropine. We did pattern in low concentration atropine in adults, and we found that there were not any significant changes in energy. So my conclusion is that low concentration atropine is a safe and effective option for preventing progression. A lot of work is still done. Thank you so much. Thank you so much.
Thank you so much for a wonderful presentation.